kennel club on the other side of the world, which is it's kind of a unique kind of thing that's come out of the COVID pandemic, I guess. So I'm a researcher at University of Queensland. I'm a physio by background, or physical therapist, I think as you guys call it. But I work for Michelle Sterling and her team in the Whiplash group at UQ. So mostly kind of my work's largely around the mechanisms underpinning injury, symptoms after a whiplash injury. But I do kind of dabble a little bit in randomized controlled trials and things we've got going on at the moment. And so I wasn't involved directly in the stress ModX paper, but it's something that was going on while I was in the department. So it's kind of nice to be able to chat about as kind of on the fence between being an outside observer and also kind of being involved as well. So.
Perfect. Sweet. And then everyone else will just say either if you're a clinician, where you're at currently, and then if you're a student, what year you are, and then where you are in school. So Paul, let's have you start off.
I'm Paul. I'm a clinician in Dallas, Texas.
Hannah.
I am Hannah. I am a clinician in Bowling Green, Kentucky.
Kevin.
Hey there, I'm Kevin. I'm a student at I was sending an email, but listening actively. So I am actually Chris's classmate. I'm a second year in Texas.
Killed it. Alex?
I'm Alex. I'm a new grad, and I'm in New Jersey.
Okay, so now it's all blacked out. Derek, if you're open to talking, if you're available.
How's it going? I am at Logan University. I'm a second year chiro student.
Joey?
Hey, I'm a new grad clinician in Dallas, Texas, or North Texas, where it snows.
Nailed it. Ben? Ben may not be there. Laura?
Oh, sorry. In a car, but I am Laura, and I am also Chris's classmate at UT Health San Antonio.
I killed it. So we may have some people trickle in, but we've got a small little group, eclectic. So yeah, Scott, you brought this Michelle Sterling paper. Obviously, as you said, you work with her. Do you want to explain why you chose this paper in particular, and then we can just kind of start from the beginning?
Yeah, that sounds good. So it's kind of in the Whiplash world, it's a bit of a landmark trial because, Whiplash traditionally has been kind of this complicated, controversial condition. You kind of can't nicely see a clear pathology on imaging or clinical tests that will explain why some people develop long-term pain and other people don't. We often have very small effect sizes from treatments that have been done for whiplash, whether it be medical or physiotherapy or whatever else. And this is kind of the first study to come up with something more like a moderate, like a medium effect size and a clinically relevant one. So that's kind of why I picked it. So I guess for a few just kind of basic statistics on whiplash. So I think the best estimates we've got about the how common it is we see about 300 per year per 100,000 population in the developed world, which, doing a few calculations, in Australia is 70,000 a year, and in the US it's more like 900,000 to 1 million people each year sustaining whiplash injury. About half of them won't get better, with 30% going on to develop moderate to severe disability. So you've kind of got this steady trickle of chronic pain patients just coming in from regular car accidents. So this is kind of seemed like a nice study that's kind of shown some kind of promise in trying to improve these numbers. The people that don't get better after a whiplash injury, they tend to have post-traumatic stress symptoms, which is distinct from actual post-traumatic stress disorder. That's kind of an early distinction to make. And they also have sorts of strange sensory things going on. So we see widespread sensory hypersensitivity to things like pressure pain or cold pain. and they also have high levels of pain and disability. So I guess current treatment guidelines for whiplash tend to be around using kind of reassurance, advice, encouraging people to return to activity and giving exercises and stuff, and simple pain relief, so just your paracetamol and ibuprofen. But yeah, as I said, that doesn't give particularly good effects. The rationale for maybe why that was the case is that if we know that half the whiplash patients get better anyway by themselves, then if you're doing randomized trials where kind of half the people in both groups are just going to get better anyway, it kind of waters down any effect of your treatment. So we thought I think one of the rationale here was to try and be able to pick who actually needs the treatment, who's going to develop long-term pain, and who's just going to get better by themselves, and exclude the people that just get better by themselves. So with the clinical prediction rule that Michelle came up with, she was able to pick the people that are at higher risk of poor recovery and then only include them in the study, which was kind of a really neat part of the design. The other thing was that's unique about this study is trying to address stress in particular. And stress is a kind of this thing that consistently comes up as being a poor predictor of outcome after a traumatic injury. And so this kind of combination of addressing stress with kind of best practice physio-medical care in the people that actually need it is, I guess, more of a precise way of approaching this from a clinical point of view, which is, yeah, I think why it's such a good trial. So obviously it's kind of one thing to come up with a hypothesis about how you might be able to really well treat pain, but then actually demonstrating it in a large scale randomized controlled trial is another challenge altogether. And so I guess the rationale coming into this trial was to test that hypothesis that kind of current best practice physiotherapy care with stress inoculation training is going to be better than just regular physiotherapy medical best practice care. So that's kind of what the study set out to find. Yeah, so I guess that's kind of the context. Does that kind of make sense to anyone? Please just yell out if you've got questions. It's kind of all, yeah.
Michelle's clinical prediction rule, could you go into that a little bit?
Yeah. So that was this. So clinical prediction rule is basically a kind of a test that you can use to try and predict or stratify risk of poor recovery or risk of good recovery. So the clinical prediction rule that Michelle's group came up with, and this was before I'd really joined the team, was the combination of the Neck Disability Index, which is kind of this measure from 0 to 100 of kind of neck pain related disability, so how much it interferes with your life. A combination of that and age, and then the hyperarousal scale from the post-traumatic diagnostic scale, which is basically the survey from one of the psychology DSM manual things that assesses the severity of symptoms from associated with post-traumatic stress. So I guess what that kind of, the idea behind that was to identify who's having a really hard time with their neck pain, who's a little bit older, and then who is having these intrusive post-traumatic stress symptoms that are kind of putting them into a hyperarousal state. And that was published over a few different papers, and you can actually access it quite easily through our website if you want a copy of it. So if you just Google like UQ Recover Whiplash Clinical Tools or something to that effect, you'll get our webpage, and then you can download it all. Anyway, so that's kind of not been nicely validated as a way of neatly being able to indicate who's at high risk, who's at low risk, and then there's this kind of awkward middle ground in the middle. It's like people at medium risk of poor recovery, but that kind of works quite nicely at 2 weeks to be able to pick who's going to not do well in kind of 3 months' time.
Would you, and this is the first paper I've looked at with whiplash associated disorders, so I'm just now learning about kind of the scale of the severity of it. Does it go up to a 4 or to a 5 for WAD?
It goes up to a 4. So 4 is basically fracture or dislocation. So I don't know anyone that actually would call that whiplash. You might just call that spinal fracture, or major spinal trauma, I suppose, is probably a better word. But the most common ones that we see is whiplash 2, which is like whiplash with musculoskeletal symptoms and kind of neck pain without kind of frank neurological involvement. And then that addition of frank neurological involvement is Whiplash 3, which is kind of your classic radiculopathy, where you've got, loss of sensation in like a clear neurological distribution, motor weakness, loss of reflexes and stuff like that. So the main problem group is Whiplash 2, because it's just the biggest one. And then also Whiplash 3 is Whiplash, musculoskeletal neck pain with neurological involvement. Yeah.
Cool. So you and I had talked that probably the best option for this paper, just to go straight down, maybe start at the intro of your overall thoughts of the intro, a little like summary, and then open it up.
Yeah, cool. All right, so I'll just bring the paper up. So I guess as far as, putting a paper together, your introduction to a paper needs to kind of establish what's the problem, and then, how are we going to, what's the issue? What do we know? What don't we know? How are we going to address it? So I suppose one thing to consider is, does the paper actually do that very well? And remember, I'm not an author on this paper, so you can be as scathing as you want. You can just don't hold back. If you need to if you have things to say, just say it. I'm not going to be offended. Any concerns with the introduction? Does it kind of make sense? Do you get a background? Do you get a hypothesis and an aim from it?
Yeah, I'm glad Chris brought up like digging into the like clinical prediction rules a little bit more, because the question that came up in my mind was like, okay, how are they identifying this population that's already sort of at risk for that? But that cleared that up, and then that's all I had on that. So I appreciate that already.
Okay, cool. All right, cool. Well, I think it kind of clearly outlines it okay. I think an important thing to consider before we kind of dive into the actual stress inoculation methodology bit is that, physios aren't psychologists. We're not psychologists. We're not medical practitioners. We're not trying to say in any way that physios can treat actual psychological pathology. So that's kind of the proviso to take into it, because it's obviously, I don't know what things like in the US, but in Australia, we kind of, in physio school, you're made aware of depression and anxiety and stress and things like that. But, we're not actually trained to do any kind of clinical management beyond saying, hey, you should probably go and speak to your GP about that. I think that's kind of an important thing to take on, is that, and I think this study actually excluded people with any kind of real psychological pathology. So again, not saying physios should be like kind of dabbling in psychology, but it's more more trying to address one risk factor for poor recovery in our physiotherapy treatment.
Now, Scott, if you don't mind, you're much more familiar with Whiplash literature than I am, I'm sure. Those numbers that we're talking about that we're trying to improve, do they also exclude those with mental health? Like, because we know depression is rampant, right? And we're excluding those people, yet those are still people that are going to be in a car accident. And are they lumped into those other groupings, right? And thus, can we generalize that this is better at treating that, or do we have to have those exclusionary scales when we're treating, right? Because now I know somebody has a history of depression, you've excluded them. Does this apply to those individuals? And it's mentioned in the paper that it may not be. And so I'm just wondering if those prior papers also were exclusionary towards mental health and some of those other kind of components.
Yeah, so for the prior papers, so there's a few big trials on Whiplash. I would have to go through the papers themselves to say if they explicitly excluded people with particular types of mental health conditions. So, you could suggest that, I would assume that you would exclude people with like kind of full-blown psychosis and schizophrenia, but you probably aren't going to exclude someone with, a mild history of depression 20 years ago. So there's got to be some line in the middle there where they did a cutoff. So I'd probably have to go and look through the papers for that. But I guess the more broad point about, I guess what you're describing is external validity there. So how generalizable are from the outset, the findings of this study? If you're excluding people with depression and significant mental health conditions, these people still get in car accidents, they still get injured. And so I think something that you also need to consider when you read through this paper is, you know, we may not be able to generalize these findings to people with full-blown proper psychological or mental health conditions. So yeah, that's that important point about generalizability is kind of something you need to keep in mind. Yeah, okay. Any other comments on introduction, or do you want to jump into the method?
I might be jumping the gun, but you stating kind of the caveat of we're obviously not psychologists or psychiatrists and we have to know what's outside of our scope. With the stress inoculation, it seems awfully similar to something like CBT or other psychological kind of interventions. How do we draw that line?
Yeah, I think probably the kind of the one step backwards is that all the physios that did this treatment had training from a psychologist and from a rehab doctor as to how to actually do it. And so I think maybe the nuance and the subtlety and the decision making around when you draw the line between what's something that I can deal with as a physio compared to what needs an onward referral to a doctor or a psych would kind of come up in that stress inoculation training delivered by an actual psychologist. So yeah, I don't have the nice neat answer to that, but I can say that our group is offering training in stress inoculation therapy via Zoom, I think, in November. If anyone's particularly interested in training in this, it's I think $200 or something for like 200 Australian, which is reasonably cheap for a 4-week kind of course. Anyway, but there's details about that on our website, so you might be able to actually get proper answers to those questions via that kind of training from a clinical psychologist. But yeah, I guess just an odd question. So in Texas and where you guys are practicing, is physiotherapy a primary contact profession, or does all your patients come via a doctor, or can people come off the street and see you guys?
We have limited direct access in Texas.
Right, okay.
So depending upon your training, it's either 10 business days or 15 business days before you need a referral from a physician. Now, other states in the U.S., some have unfettered, or others have other mitigating components that they have within their direct access.
Right, okay. So I guess within that, and direct access of any kind, and I guess there's that responsibility when you're seeing someone, if trying to decide, is this person actually, is this person presenting with something within my scope of practice, or do I need to refer them to the medics or someone else to get more appropriate care? So I guess all this talk around the psychopathology and physios not being psychologists is kind of taken in the context of more broadly, with everything we see. If someone's got a wound or a funny looking mole or anything like that, like you have to kind of pass them on to people that are better trained to deal with it. So yeah, maybe that's kind of the context here.
Scott, I have a quick question that there was I don't know who posted it, what clinician, but it was like, and I bet other people have seen it. I think it was yesterday or the day before. And it was like, physiotherapists are not psychologists, but they're also not biomechanists, or they're not exercise physiologists. So it's like arguing the point of what is and is with like not, and like, what can we do? And like, when do we refer out to actual like specific professionals? Because we are such a generalized profession. So I just thought it was kind of thought provoking of like, what are we from that perspective? Like, I mean, physiologists know more about physiology, biomechanists know more about biomechanics. So it's like, I don't know. That just made me think about the psychology thing.
Yeah, that's a great question, because it's, the comment come up from Kevin about the rabbit hole of scope of practice, which is absolutely correct. It's kind of, I know in Australia it's kind of vaguely defined as something like, whatever you're competent in, which isn't that helpful in drawing a line. Like, I feel like, you obviously can't prescribe medicine and you can't perform surgery, but then, like where do you, anyway, but it's a good point. I think it's probably varies between jurisdictions and insurance companies and things like that. But I suppose from a personal point of view, reflecting on your own training and competence is probably a good starting point too. But for the actual rules around it, you'd probably need to speak to the licensing folks and yeah, people from that point of view. We had this tricky thing. I'm involved in a research project with Nina Schmid, the neuropathic pain researcher in Oxford, and she's a physio by background and somehow was able to do skin biopsies. So that involves injection and kind of taking a biopsy of skin as part of research. And research is a bit of a weird sphere anyway. Kind of the ethics folks say as long as you've got training, it's fine. But there's no definition as to what training is. So anyway, scope of practice is a bizarre thing, changes around the world, and no one has a nice answer for it, I think, in physio. So yeah, that's a complicated discussion for another day, maybe. Yeah. Cool. All right. So I guess that's kind of the introduction. Kind of explains the context as to what they were trying to do and why they were trying to do it. And then I suppose then the method is kind of probably the more important bit to actually explain how they were going to do it and why. Sorry, how they were going to do it and the details about what they were going to measure and interventions and stuff. So I guess more broadly speaking, it was a randomized controlled trial. It wasn't double-blinded; it was only assessor-blinded, but it did use randomization and kind of a parallel approach. So you kind of had a stress inoculation arm and a standard care arm going at the same time. The recruitment of patients was done via emergency departments as well as advertising, and they were trying to get people within 4 weeks after a whiplash injury, which kind of is that time frame where it's enough where it still counts as acute injury, but it's kind of enough that people have realized that their neck hurts and they probably are interested in doing something about it, and it's not just getting better by itself. So that's a pretty common time frame for whiplash injuries. We've been trying to do one the last couple of years out of emergency, trying to enroll people within 48 hours, which has been a challenge because, yeah, everyone thinks they'll just be fine, and then by the time that they realize that it's not going away, then it's kind of too late to include them. So anyway, so 4 weeks is a good amount of time. The inclusion and exclusion criteria, so it's Whiplash 2 and Whiplash 3. So again, excluding people with any kind of fracture or bony injury or ligament disruption or anything like that, which is pretty standard. And then, as we spoke about before, using that neck disability index and the hyperarousal scale from the PDS to identify people that were at risk of poor recovery. So I guess the two things from that is that from a health service point of view, it's probably a waste of money to treat the people that are going to get better anyway. And it also can potentially contribute to worsening outcomes. If you overtreat someone that's just getting better anyway, then there's evidence that actually leads to things getting worse in whiplash patients. So we obviously don't want to do that. Then I guess the other side of it is that from a statistical point of view in research world, that if you'll get you get nicer, neater, more exciting results if you exclude the people that are getting better anyway, because that'll just water down your effect size. And anyway, so we've spoken about that before. I guess, and then the other kind of main exclusion point was around excluding people with actual psychopathology. So that's, again, probably more being sensible within that scope of practice question for physios, but it's also will have an effect on the generalizability of the findings.
Scott, do you think that, there could have been another branch off of here, right, where we're looking at just what the psychological component was rather than having any additional exercise component within? Because we know contextually people can get well just because of the context of delivery, right? And so sometimes just dealing with that effect. And so, seeing another branch, it might just be because we water down too much, right? We're trying to spread too many people. But I was wondering why we didn't just see what that psychological effect was. We're assuming A plus B, right? The therapy plus the psychological has this additive effect.
Yeah.
It's equal to just the exercise component, but we're not sure because now we've added a different context and this is a different contextual. And I'd like to see what just that context was within that.
Yeah, that would be interesting. I think there have been trials done where it's kind of largely psychology driven. I don't know if it was stress focused. I think it might have been CBT more broadly. But yeah, from a pure research design point of view, that would have been much nicer. I guess that's the things you can do with mice that you can't do with human patients, where you can not treat people and see what happens, or you can do a bit of something and not of others. But I suppose from maybe a research ethics point of view, the idea was you want to make sure everyone in your trial gets kind of standard guideline-based best practice care. And for whiplash, that includes physiotherapy and exercises, at least in Australia. And so I suppose that's maybe where that's coming from. Because
that's fair. That's fair.
It would be tricky to
that's just
pull
a
out
branch
the
I'd like to know.
exercise bit. Yeah.
Just that contextual was right. Yeah.
Yeah. Maybe we could stress out a bunch of mice and see what happens, and try and have I don't know how you have psychologist input to mice, but that's, I guess, another question again. But yeah, no, it's a nice point. Anyway, yeah, so I guess the other main bits of is the method. So there was randomization. So that's, again, pretty inherent to a randomized controlled trial. But the idea behind randomization is that you try to account for all of the potential confounding factors that might influence the main outcome of interest by just randomly splitting them between the groups. And then I suppose we get to the intervention, which is the important bit. So patients were either randomly allocated to kind of normal standard care, best practice, physiotherapy, exercise, mild pain relief as needed, blah, blah, blah. And that was delivered by physiotherapists that received training from Michelle Sterling, which probably a pretty good person to get trained on whiplash from. And then the intervention group was that same standard physiotherapy care plus stress inoculation therapy, which was this kind of series of kind of pseudo-psychology interventions looking at identification of stress, relaxation strategies, problem-solving ideas, muscle relaxation. They kind of outline it in that table, and kind of applying those kind of coping and stress strategies, I suppose, into the real world and then into their real life. And I guess it's in the few patients that I've had a bit of a chat with in our research studies, stress is one of those things that can really come across. Some of the conversations you have, guys that are barbers that suddenly they can't stand over and do a haircut, and they lose their business, or they can't look after their kids. So stress is something that we really commonly see. The other big thing associated with stress can be dealing with the insurance system. So in Queensland, in Australia, your road traffic insurance will cover medical costs if you're the person that's not at fault, but they won't cover your medical costs if you are at fault. So we have public healthcare in Australia, but it's obviously not as kind of liberally given out as an insurance company would pay for it. So it's there's kind of a lot of stress around the compensation system and healthcare factors from that point of view. So obviously there's a bit of variation between different countries and jurisdictions in the world and how healthcare systems work. But I think that's another big major point of stress. So I think a lot of the stress inoculation therapy things would have been directed at those factors that we know are a big deal for patients that have these kinds of injuries. But I suppose for a quality assurance point of view regarding these interventions, so you had the exercise was kind of trained and had kind of fidelity checked by Michelle. And then from the stress inoculation therapy, that was trained and checked by a psychologist and a rehab doctor. So they were trying to teach these things to the physios and make sure they were good at doing it before they actually started delivering it to the patients in the trial. We also gave patients the Whiplash Advice Guidelines, which is this booklet that Michelle and Gwen Jull had written back whenever. But that's also available on our website too. So you're welcome to, again, it's on our Recover, click Whiplash Clinical Tools section, so you can download PDFs of all that stuff if it's of any help. And so this combination of exercise, advice with or without stress inoculation was the main treatment. I think one thing that's important to consider is that the treatment times and time with the therapist was the same between the stress inoculation group and the standard care group, because as you mentioned, Paul, there's all that kind of contextual stuff around therapeutic rapport and the placebo effect and all that kind of those things that come with the ritual of seeking healthcare that can improve a patient or have the opposite effect on a patient. But that all needs to be considered. So if the people in one group just got more healthcare than the other, then that's something that could potentially confound things. So that was addressed by having the same amount of treatment time. Regarding the outcome measures, so the primary outcome measure was the neck disability index, which is, as I said, this kind of 0 to 100 scale assessing the amount of impact that neck pain has on someone's life. Then there was this kind of whole big bunch of secondary outcomes, which kind of spanned a bunch of psychological factors, so pain catastrophizing, post-traumatic stress symptoms, the DAS, as well as kind of pain and general recovery experiences too. So in research, we love giving people questionnaires. So there's always a million questionnaires we give, but the main thing that everything was kind of powered around was the neck disability index, which is kind of the standard thing that we use to measure someone's recovery after whiplash. Any questions on that so far, or it kind of makes sense?
Scott, I had a question about, oh geez, I just totally forgot it. I'll come back to it. It'll hit me.
All good. But I know the stress inoculation thing is the hardest thing to explain, and it's even worse, like talking about it in lectures like last year when we weren't offering courses and didn't really have anything to explain it. I just felt so unsatisfied giving this kind of vague description of stress inoculation training, but
I remembered my question. Okay, yeah. So you had mentioned that they parallel, like the stress inoculation and physiotherapy exercise and just standard exercise was time equated. So like for session 1, for the example, for week 1, they had for SIT and exercise, they had both of those obviously. So was the exercise session just super condensed if they were both time equated?
That's how I'd interpret it. I think you kind of can't compress the minutes, right? So they're gonna, if they're getting this extra stress inoculation stuff in their 50 minutes of physiotherapy treatment, then it's gonna be at the expense of the exercise time. I guess one way, from a design point of view, that you could deal with that is maybe just in the control group, you could just have the physio have a friendly chat for 20 minutes or something to try and offset that. But I don't know if they actually did that in this study. So in theory, the stress inoculation group could have had like a portion less exercise every single treatment, which is worth considering.
And then didn't they also mention earlier on that on top of 2 times per week of these sessions, they were advised to do the same program once per day at home? Did I read that correctly? Or were they advised to do some other type of exercise at home?
Yeah, I think so, because it was 10 sessions over 6 weeks. So that's just the maths there is going to mean that there's some time doing supervised exercise with the physio, and then other times it's going to be at home.
Yeah, it said under guidelines.
Oh yeah,
they were encouraged to perform the exercise at home once per day. So I don't know if that meant like they're encouraged to perform like a set of the exercises or like the whole routine all over again.
I think it's it must be the exercises themselves. I know that there was an element of assessment and tailoring the exercises to the patients by the physios, which again is what you do in the real clinical world. And so I think I suppose there might be an element of pragmatism in exactly which ones they did were encouraged to do at home or not encouraged to do at home, or which ones to focus on. But then I suppose there was also a logbook at home that they used to try and record the amount of exercise that the patients did, which I guess is a way of ensuring some kind of consistency between the groups as well. But yeah, that's all certainly relevant points.
Scott, a little bit off topic, but just along the lines of like objective testing. How much, like during your typical whiplash assessment, do you look at like smooth pursuit, saccades, like more like VOR type stuff, if at all?
Not something I do in my research very much at all, but I know that Julia Treleaven, who's at UQ as well, she's kind of all about that. And so I think in her research, it's a large part of it. And so I suppose how you would incorporate that into clinical work would be, I guess it would kind of come into that, almost that risk stratification thing. So if you think someone's going to get better by themselves anyway, then just leave their eyes alone, just let them be. But like people that are either at risk of poor recovery or having this kind of drawn out problems, then I think that might be when you start to delve into more of those specific, more complex assessments.
Okay. What can you say her name one
yeah.
more time so I can look at her later?
Oh, so Julia Treleaven. So Treleaven.
Thank you.
Yeah, she's done a lot of the work around, saccogenic dizziness and things, kind of sensory motor dysfunction within whiplash. So she's, someone who's probably worth having a bit of a read from.
Thank you.
No worries. Thank you, Chris, for putting that up. All right, cool. So I guess the other thing I wanted to mention regarding the methods was blinding. So in a drug trial, it's really cool because you can blind the doctor or the nurse who's giving the drug, because it's just a pill. And you can blind the patient and you can blind everything. But in physiotherapy, you kind of can't really blind the physio to what treatment they're delivering. And in this particular trial, they couldn't blind the patient to what treatment they were receiving. So, I mean, you could pretty easily pick if you're receiving stress inoculation therapy compared to exercise only if you're a patient. So I think that kind of lack of blinding for those aspects of the trial, you probably need to consider as well. But there was blinded analysis. So the actual stats were blinded, were performed by a statistician who was blinded. But there was also the person assessing the patients was blinded too. So those are inherent risks of bias that might come with either delivering the treatment or the patient receiving the treatment that you should probably be mindful of too. So I think probably we're up to stats then. So I don't know how flashy you guys are with statistics, but basically the approach that these guys used was a linear mixed model, which I mostly do cross-sectional work, so I'm definitely not the guy to try and explain it, but I think it's basically the way it comes together. It's a more fancy version of the repeated measures ANOVA. In that, if you think of a repeated measures ANOVA, you take kind of measures over time. If you have any missing data from repeated measures ANOVA, it kind of cancels out that entire patient. So linear mixed model is a nice way to, is better at kind of adjusting for any kind of missing data. It also has a way of incorporating kind of both fixed and random effects at the same time. So the fixed effect might be something like group or time or something like that, and then random effects is the treatment or the outcome you're interested in. So again, I'm not a statistician, not the guy to explain that, and I'm sure that's not the best explanation
that was
ever.
More succinct than most of what we'll get from anybody teaching that shit. So,
well, yeah, succinct is probably a polite term. So thank you. Anyway, but that's the analysis approach, and I guess the things to consider here is that they have a sample size calculation, which is important, and the sample size calculation is based on a t-test between group differences, and it was the minimum difference that they were looking for was what you'd consider the minimum clinically relevant difference in the NDI, which was, I think they said 10 points or something like that. And so that's relevant for a few reasons. It means that we're kind of powered to actually be able to find a relevant difference, because you're not just it's not just all about finding that p-value below 0.05. And the other thing is that by actually including a sample size calculation, that means that if the trial were to give a negative result, it means you can actually take that as being an actual negative result as opposed to just being an underpowered trial. So the presence of a sample size calculation is important. The other thing to consider with randomized controlled trials is the use of an intention to treat analysis, which if you guys all know of this, you can just kind of say, yeah, I get it, I know what it is, or if this doesn't mean anything to you, I'll carry on. But intention to treat is when you, for the most pure, least biased approach to analysis, is that once someone is randomized into a group or not, you include their data in the analysis. So regardless of whether they drop off from they withdraw from the trial, kind of 2 days later, you still have to include their data in the analysis. So they might not even do any of the treatment, but you include them in the analysis. So you see a few trials where they'll call it a modified intention to treat, or a kind of they'll only include the people's data who actually completed the treatment, which is actually not best practice when it comes to analyzing a randomized control trial. So the words intention to treat analysis in the statistics bit are pretty important, because that's kind of the least biased way to analyze the data. Because obviously, if you've got a bunch of people that drop out, then they probably either hate the treatment for whatever reason, or the treatment doesn't work, or it makes the symptoms worse. And so then if you don't include the data, then that's not going to give you a true reflection as to what the treatment actually did. And so, yeah, that's just the way that Consol recommends to do the analysis. So anyway, so that's intention to treat. Then the other thing is using effect sizes calculated with Cohen's d. So that's effect size is a way to actually, if you identify a statistically significant difference between groups, effect size is a way of actually statistically demonstrating how big a deal it actually is. So you might find that p-value below 0.05, but if the effect size is tiny, then it's a statistical way of saying, like, so what's the point? Whereas if you've got a larger effect size, then that means that, hey, it's probably worth paying a bit of attention to. Yeah, and then that's probably the main guts of the analysis. So and then patient involvement, and that all seems, yeah, not that big a deal. Cool. Thanks, Shelby. All the best. Yeah, all right. So any thoughts on the method or the stats side of things? If you're all statisticians and I've just kind of butchered analysis of any of those things, then my apologies. But but otherwise, yeah, any questions, concerns, thoughts? All right, cool. Well, we can push on to the actual results. So
actually, Scott, with Whiplash, can I just use the car analogy? Can we rewind back to the secondary outcome measures they were looking at, and sort of going through those? I was wondering, like, what exactly they were trying to get at with those, like, just looking at that clustering of, like, the DASS, the PDS, like, what do you feel like? And some of those I've heard of before, but what do you think their aim was, like, picking those ones out?
Yes, that's a good question. So I think there's probably two main aims. The first one is that probably, if you notice in the depression, anxiety, and stress scale, there's the word stress, and there's an actual subscale for stress. So I think a neat thing when you're doing stress inoculation therapy is that you probably want to measure stress. So, if we're trying to actually treat stress, you should probably know if you've done anything to stress. So that's, I think, part of the rationale, including that particular thing. And same with the PDS. So that's a post-traumatic stress kind of scale, symptom scale. The other factors are things like depression, anxiety, catastrophizing, pain self-efficacy, and things like that. That's kind of, they're all confounding factors. So if you found that one treatment group was really depressed or like highly anxious or something like that, then that's, and the other one didn't, and the people that weren't anxious got better. Well, I mean, that could have just been because you had two different groups of people that one of them had a big risk factor for poor recovery. So it's a way of trying to address some confounding factors there too. And then the things like the global self-improvement, I don't know why they pull that in. I mean, it's kind of seems like it's just another way of asking the neck disability index, but just with smaller numbers. But pain intensity is probably a pretty relevant one to look at too, because people don't necessarily come to you in the clinic and say, hey, I've got some neck pain related disability. They say my neck hurts, and the pain is an important part of it. And so I think measuring that's a relevant outcome to keep track of too. But yeah, so I suppose that the large number of secondary outcomes is, one, because researchers like questionnaires, two, because I guess whiplash is a complicated thing and there's lots of different stuff all going on in people's lives and as part of the condition. So I think being able to try and have a bit of a comprehensive measure of what's actually going on is an important thing to measure. And then I guess, but then the reason something is made a primary outcome is because that's what you do your sample size calculation based on, and that's kind of what your hypothesis is based on and everything. So you kind of have to pick something and say that's the most important, but you're kind of saying all these other things are kind of important too, so I'm going to measure them as well. Yeah. Yeah, but the secondary analysis, the secondary outcomes thing is tricky. We've just finished a drug trial on use of pregabalin for acute whiplash injuries, which is kind of interesting in itself. And the main drawback that we've had from ours is people just don't want to do questionnaires. Like if we just keep sending them this like swathe of questionnaires of, tick the box things, people just hate doing it. So I think that there's a happy balance somewhere between getting enough kind of comprehensive depth of your data and then also just annoying all your participants so that they drop out and don't answer your emails. So it's an interesting area, I suppose.
Do you think like some of them, like the DAS, right? I mean, that kind of thing is it's almost the same as what the inclusion criteria measure is, right? It covers a lot of those same kind of components, right? So this is a way of second checking yourself. So I've got a couple of other figures of things that cover maybe some slightly different components of what the NDI may be. So it's a way to give me a secondary analysis if the NDI doesn't come out real strong, or a way to look at maybe one measure was the driving force of why the NDI changed, right? So a way to check and see if there's any kind of a component shift that occurred.
Yeah, that would be a way you could kind of pull a little bit more into the results as well, particularly if there wasn't a significant group difference. So if you found that this treatment didn't affect neck pain and didn't affect neck disability, but improved stress, then that's kind of good to know anyway. Or you might find that people develop, because you're taking these measures over time, so you might find that people are the same, the two groups are the same. There's not that much depression, anxiety, or stress at the kind of the acute time point. But give it 6 weeks or 6 months, if the people whose pain has continued and they've lost their job and it's causing problems in their marriage and all that kind of stuff, then you might see all these kind of psychological numbers start to creep up, and that's all really relevant as well, because we like to think about things like pain and muscle strength and joint range of motion and physio, but the things that are important to your patients are generally much more broader than that. So they're good to know.
Scott, with the stress inoculation training, was there a standardized model of like what that inherently is or how to go about that? Or was this paper like, we're taking the concepts of stress inoculation and making sessions just based off the principles?
I think it's based on other models of stress inoculation training. I think Rob Schmitz, who's the rehab doctor that was involved, I think that's an area of his real expertise. So I think we're certainly not the first trial to do it. I imagine it might have been adapted a little bit to the Australian context, or to fit into a physiotherapy model. As I don't know, maybe if it's done by other professions, that they might need to be tailored a little bit. But I think they probably give a bit more of a detailed explanation in the supplementary material on stress inoculation training, or you could go to the get actual, like, have an actual psychologist talk about it to give you a better answer than my vague fumbling through it. So so I imagine it's tailored a little bit, but it's based on this kind of established stress inoculation training model.
And then on the other side, when you said Michelle Sterling was the primary person training the physios on the exercise component, is there a standard like exercise protocol for whiplash disorders, or is it like we have these set of muscle groups that we want to hit? Like, what does that look like?
I think the way that they did it was they had a set of exercises and things, or a kind of bunch of different exercises within the whiplash recovery booklet that we had, and then there was an element of tailoring the exercises to the patient. So the physios might be looking at, if the patient has really poor range of motion in one direction, then that might be something you'd try and target. Or if you had particularly weak muscles, you'd take the extensors or the flexors, then that might be something you target as well. But so I think there was kind of a bit of trying to find a Goldilocks area between here's the standard exercises we want done and giving the right exercises to the right patient. yeah, so that's, yeah, I suppose it's the like common sense stuff that you do when you're actually managing patients, but trying to package it in a little bit of a standardized research way too, which, yeah, is a challenge sometimes. All right. Cool. Any other thoughts about methods, or happy to jump into results?
I'm kind of curious. I guess it said the standard of care is the exercise program. And in Australia, like if someone walked in with whiplash, would you just jump right into the exercise, or do they do any sort of manual or modalities or anything like that?
I think that, so the main things that we do is, advice and education is kind of the first bit, and then simple analgesia is the other bit. So it's that awkward thing in physio. You can't tell someone to go and take medicine, but you can suggest that maybe go and talk to the pharmacist about what simple pain relief might be relevant to you. Yeah, and then exercise is kind of the other part of it. So generally, it's active exercises is good. So anything with activating muscles and moving, just basically keeping moving, basically while everything settles down. As far as manual therapy goes and all that other stuff, I think it seems like it's okay to use as an adjunct when kind of appropriate or indicated. So I think manual therapy on its own doesn't necessarily have much of an effect on outcome after whiplash, but I think just kind of from a clinical pragmatic point of view, if you've got someone that's got a really stiff, sore C5-6 kind of level, then giving some manual therapy to mobilize and kind of improve range of motion of that kind of joint, I think that's a reasonable thing to do.
But
in the context of all the other stuff. Sorry.
But in this study they didn't do that. They just went right into the exercises.
They did have a part like at the physio's discretion.
Right. They just made sure it wasn't a primary part of the intervention.
Yeah, there's that sentence. I think it's at somewhere in the intervention bit. Yeah, there's this kind of little comment about manual therapy.
So it might be just kind of variable from participant to participant. Okay.
Yeah, pending the physio's discretion. So that might be, because I guess with any kind of treatment for like trial and whiplash, you can't tell people to not get other treatment. That's just not ethical, but it's also just not how the real world works anyway. So if you kind of, so if someone would really benefit from manual therapy or from whatever else, then you're allowed to add that in if it's clinically indicated. But I guess it's all just kind of recorded and kept in those notes and logs from the physios and the patients.
Okay. Oh, that's interesting. I feel like here, pretty much most therapists would give manual. I kind of think part of that's probably because of like the payment system, stuff like that. But so it's just interesting to hear how you guys do it, where it's more if it's indicated. Like exercise is kind of the bread and butter, but then it's like, oh, this person really needs the manual, then you'll bring it in. So that's interesting.
Yeah, I mean, lots of people are different, and there's kind of some people are very, very hands-off approach, and other people are very hands-on. And I think the sensible thing is to kind of do what works for the patient and do kind of what you think is clinically indicated. It's kind of that, if you think of that evidence-based medicine kind of trio, it's this like research, patient expectations, and clinician experience. And so if it's kind of seems like the right thing to do with that patient at the time, then I think that's a valid thing to do. So it's, but yeah, I think it certainly can vary a little bit between jurisdictions. And I suppose also, the clinician's training, if you've got particular manual therapy training and you're really good at it, then you're probably more likely to use it. Whereas if you've kind of come from much more exercise focused, or you've come from a chronic pain clinic where everything's about active management and giving, like, kind of trying to take away medicine and take away hands-on passive therapies, then that might not be something that you go for. So we all have our own kind of or kind of context that we make decisions in, I suppose.
Okay, cool. Thank you.
Yeah, okay.
Is because you said y'all's center is only studies whiplash or neck-related issues. Is that correct?
Mostly, yeah.
is there many other places in Australia or the world that have that like specific focus?
Yeah, a few places around the world. So as a research center, so us at UQ have a kind of, we've kind of been there for a while and studied Whiplash for a good while. There's also a group in the University of Sydney that do a lot of work around it. James Elliott, who's actually from Chicago, an American, who's kind of now at University of Sydney, he does a lot of work around imaging. But I think from the treatment point of view, there's Trudra Rebeck and a few people like that within that Sydney group. And then I think in the US, there's probably a few folks around, and then in Europe, there's I know Joe Niche and some guys in kind of Amsterdam and Belgium that they do a lot of work around Whiplash too. So there's bits and pieces of us around, and we collaborate a lot with University of Southern Denmark. There's kind of groups there that are involved in Whiplash a lot. So it's there's a few of us around, and we kind of all have our own slightly different takes on it, but we keep keeping it. Yeah. All right, we just lost Paul. So yeah. Cool. All right, so maybe we go results. So I think probably first things to consider for the actual results was the response rate. So they got about 90% in one of the groups and kind of 89 for the other, which is pretty good. They got the sample size they were looking for, so that's also relevant too, because it means, again, that the study is appropriately powered to find the difference or not find the difference they were looking for. And then I suppose probably the most important bit is the primary outcome results. So they did find that there was group differences at the different time points that were clinically relevant between the intervention group and the control group. And so that was kind of around that about 10-point difference on the NDI, which is kind of that clinically relevant point. And it's also kind of backed up a little bit by the Cohen's D. So you can kind of see it goes between about 0.5 and 0.7, which is in the realm of a moderate effect size from a statistical difference point of view. The, I guess, secondary outcomes. So it seems like the stress inoculation guys had better responses on a lot of the secondary outcomes. So if I'm just looking through it, so 6 weeks, 6 months, and 12 months. There was a difference in stress, which is good if we're trying to treat stress. That's good to see that stress is different between the two groups. But then other things like depression and pain intensity, which is neat to know too, as well as global recovery. So I think you kind of interpret that from a primary outcome point of view. It kind of showed there was a difference we were looking at looking at it at the early time points, and then that was sustained through to the later follow-ups. But then there was also some improvements in the secondary outcomes in this treatment group too. So that's kind of cool. Anything else major from there? I think that's probably the most important things to consider. So I guess the other thing is that there was no major adverse events. So no one, I don't know, you kind of can't have an overdose from exercise or stress inoculation, but there was, I think, one person had a flare up of pain and that kind of settled. No one was kind of ticked across into a psychiatric admission or anything like that from dealing with stress or not dealing with stress. So that's good as well. I think that's probably the main bits from the results. So it's kind of, does that all kind of make sense to you guys?
I was actually kind of surprised with like how high the adherence was, like of people and less dropout. And one thing that I sort of wondered about going through this section, going back up into the methods, at the end of the methods, it mentions that, I'll just read it. The sample size proposed in the original protocol was included at 15% loss to follow up. And then we decided prior to the trial commencement to increase this to 20. And this increased the sample size from 100 to 108. And I kind of was wondering, like, about what what that decision meant for them. Did that help them like power the study better?
So that's kind of percentages above and beyond the power needed. So I think they would just so you often you come up with your sample size and then you add on like 15%, and so they then to account for a bunch of people just kind of not turning up or dropping out of the project. So the idea is that you don't want to aim to recruit the exact number that you need, because if like a bunch of people just kind of drop off and stop responding to your communications, then you aren't powered to detect the differences at the follow-up time points. So their rationale was, we'll assume 15% won't turn up, or 15% will withdraw, and then we'll still be powered for what we need. And so I think with the increase to 20%, they must have maybe were feeling a little bit nervous, and so wanted to recruit more and more people to ensure that they didn't have that dropout that got them below their threshold for the sample size calculation.
Okay, got it. So that's more just to protect the power that they've initially set out with, and then they're accommodating for it in the essentially over recruiting to sort of.
Yeah, that's exactly right. So it's like an airline thing, right? They do overbooking where they kind of sell more tickets than have on the plane. It's kind of the same idea. Okay. That you recruit more people than you need because you just figure some will just drop off. Cool. In a very cynical way, I wonder if they'd just suddenly gotten more research funding and needed to spend it or something like that. That just these things are expensive, and so 5% of your sample is a pretty decent amount of money, I guess. So anyway, that's a little bit tongue in cheek there, but yeah, for whatever reason, they just wanted to be more conservative, or they had the ability to recruit more people than needed. And then that just ensures that when it comes to that 12-month follow-up, you're less likely to be underpowered for your analysis.
Scott, do you know, like if you're looking at just like, however you want to call it, non-specific or multifactorial neck pain compared to WAD, what does anything change in your treatment protocol or your thoughts from like a research and kind of standard practice perspective of how you look at that differently?
I think how you treat it in a clinical point of view, you would just have to be mindful of the potential role of trauma and stress with these patients, with whiplash patients, compared to people without that traumatic injury. In research world, there's kind of lots of neat things that show that physiologically there's different things going on in these two different groups of patients. So neck pain patients that haven't had a traumatic injury, they'll have less pain, less disability on average. Also we see in the whiplash patients, we see the widespread hyperalgesia. So they'll have reduced pressure pain thresholds, if that means anything. So they feel pain with a more mild pressure stimulus, say on their leg or on their hand, as compared to, so if they had whiplash, as compared to people that have just non-traumatic neck pain. When you do MRI scans on the neck in whiplash patients, they have infiltration of the muscles in their cervical spine with fat, which doesn't happen in patients that haven't had a traumatic injury, which is kind of weird. And so we basically see more of these central changes, these kind of signs of central sensitization in the whiplash patients as compared to the people that haven't had a traumatic injury. So we don't really know why that is. We think maybe it's related to some kind of cascade that's set off by traumatic injury that leads to this kind of systemic stress system dysfunction in some people. But yeah, they are a different group from a physiological point of view. But as for how you would deal with them differently clinically, you just kind of need to be mindful that trauma is obviously a big factor in people that have had a traumatic injury. Now, it's not everyone. Some people they were just sitting in the traffic lights and some idiot drove into the back of them and they're just now annoyed because their neck hurts. But then there's other people that have had a really scary traumatic injury, or it's been an assault or any other kind of thing, and you really have to be mindful that stress and trauma are very clinically relevant factors to consider.
And I guess that kind of parallels with a lot of the just psychosocial literature with how impactful it is for a lot of these persistent pain cases in general. Like, I guess this could kind of be extrapolated to any other situation in which their kind of beliefs and anxiety or fears may have more of a effect than the actual like structural change potentially.
Yeah, potentially there's that potential role of there's what the kind of fear avoidance model around around pain and developing chronic pain, and that the fact that pain catastrophizing actually will predict who develops chronic pain after surgery or after injury and things like that. So it's kind of looks like there's certain psychological characteristics that put you at more risk of transitioning to chronic pain. And then work being done out of North Carolina largely by a group at Chapel Hill. So there's an ED doc there, Sam McLean. He's doing projects looking at blood markers and genetic markers and molecular markers for stress system dysfunction. And him and Sarah Lindstadt, who's the kind of the other researcher doing a lot of this work in his team, they've been able to pick from particular blood markers of kind of molecular biology or using genetics to find evidence of stress system dysfunction in patients on the day of their car crash that predicts who's still got pain in 6 months. So you can tell, from a research point of view, you can tell on a blood test on the day who's going to recover and who isn't. And so that suggests that if, and that's certainly not ready for clinical use just yet, but that's kind of where it's headed. So the rationale is that there are some people with genetic factors that mean their stress systems don't work that well, and when they get injured, it kind of sets off this cascade of events that leads to pain. And so I guess it's that there's kind of ongoing, this kind of established psychological patterns, as we kind of said before, but then it's kind of these emerging evidence of stress system dysfunction that looks to be kind of maybe part of the key as to why some of these people don't get better, and why other people can have the same injury and just recover with no problem. So a lot of work to be done, but it's kind of that. I don't know. I think it's cool, but it'll be interesting that if in 50 years time, if you just get a blood test in ED and that determines whether you get the referral to the psychologist and you get this or that, or how it's all actually going to come together.
Do you think that could potentially, because I mean, you could do like the genetic testing now and show you have like a SNP of like a predisposing you towards like diabetes or obesity, and that kind of I don't know what the right word is. It coddles you to believe that that's gonna be your trajectory. Like, do you think if someone gets a blood marker showing like day one that they're at a higher risk, like how do you, because that kind of you've already self-selected them to believe a certain thing. I don't know.
Absolutely, yeah. So I that's another kind of minefield, isn't it? So with the clinical prediction rule, we have the same issue. It's kind of, what do you do when someone completes a survey and they're at high risk of poor recovery? Do you say, hey, well, statistically you're not going to get better, so enjoy? Like, that's like, what do you do with that from a clinical point of view? Or do you not tell them? And then people kind of feel like they'd like to know, if I'm at risk of having a hard time by this, I probably would like to be aware of that. I don't know. I don't know what the answer to that is, but there's probably some kind of delicate wording somewhere to be worked out over the years as to how you cross that bridge.
Anyway, with the exercise in whiplash associated disorder, maybe just neck in general, of what do you think the mechanisms are of like why it's beneficial? I know, as you said early on, like with whiplash, it's kind of small effects, even though it's kind of like the standard of care at this point. Do you think it's less of like you're strengthening the musculature of the neck, or is it you're kind of, it's almost doing the physical job of the stress inoculation, where like you're giving the organism like the input that's like, it's okay to load these positions and to feel comfortable? Like, do you think it's less of like a structural change and more of like the process of exercise? I don't know if that made sense.
Yeah. So I don't know, I guess is the brief answer. I don't know, but I think that the hints where it could be is that having, at a very kind of local level, having your facet joints moving, that's going to be a good thing, and addressing stiffness in those kind of joints, and getting the muscles contracting and muscles trying to get them activating at a neater kind of coordination than we kind of know happens from a dysfunction point of view with these whiplash patients. But then I guess more broadly from a neuromuscular point of view, then you're going to have improved representation of these muscles within your motor cortex, and that kind of signaling between the two different kind of from this end to the neck end of it's going to be improved potentially from that work. There's also what's known as exercise-induced hypoalgesia, which is the where you get a reduced pain sensitivity following exercise. So that's kind of a nice, neat kind of neurophysiological explanation as to why in some people exercise leads to pain relief. And then also might be other things. I mean, we know that in these whiplash patients, they have systemic inflammation. So again, like these guys have raised CRP, they'll have raised interleukin-1 beta, and inflammatory markers in the blood, raise after a whiplash injury, and in the people that don't get better, they stay raised, and the people that do get better, the inflammatory markers go down. And we know inflammatory markers, they make you feel bad, like you feel sick, you can lead to low-grade fever. It can lead to sensory hypersensitivity. So you can actually, your inflammatory markers in the blood will sensitize the nociceptors throughout your periphery so that you feel pain more easily. And so there's this kind of, that you could kind of think of things at a joint and muscle level, and then kind of a neuromuscular point of view, and then there's kind of the systemic, all medical stuff going on from a physiological point of view. And that's, as to exactly how you pull it all together to be an effective treatment, I think that's still all got to be figured out. But I think exercise is going to contribute to that somehow, whether it be by movement or getting the muscles working, or the psychological benefits, or the kind of increased confidence, maybe a combination of everything. Yeah.
Do you know of any studies that have compared like neck specific exercise to like only solely like lower extremity training, or just like aerobic walking?
I have heard it talked about. I don't know the studies off the top of my head. I know there's a systematic review from a couple of years ago saying there was no effectiveness of general exercise on chronic whiplash, but they only found like one study, so it was kind of a little bit of a misleading review. I think it's something that's being looked at a little bit more broadly in back pain now as well. So I think, I think it's probably a promising area, but I don't know if we have enough sophisticated data yet to actually comment on that. A colleague of mine, Rutger Deserter from University of Adelaide, is done a kind of a pilot randomized controlled trial of just general exercise for people with chronic whiplash, where he's using brain imaging as an outcome. So he's trying to tease out is there a neurological mechanism underpinning improvement in symptoms with exercise in whiplash patients. So I think we'll probably, as more research is done on this, we'll have a better idea as to what's actually happening from a mechanistic point of view with exercise. But at the moment, we're kind of just speculating.
Have y'all done, or do you know of any like qualitative specific papers for whiplash of like patients' beliefs about what happened or what's continuing to go on?
Yeah, I think it has been done. It's not an area of my research. I kind of do more work with microscopes and numbers, but I think, there has been work done. I think Samantha Bunsley out of University of Melbourne has done a bit of work in this field, kind of looking at the qualitative aspects of the experience of whiplash injury. And so I think that's all would give relevant insight as to what's going on in patients' heads as they're kind of trying to make sense of everything. Anyway, so it's one of those areas where kind of you can certainly go down a rabbit hole of what's potentially going on and what helps and what doesn't help. I suppose trying to then bring the findings of this study into that grand context of things, it's kind of seems like, I guess from the results point of view, it's going to shows that incorporation of stress inoculation and training into current guideline-based therapy with exercise is beneficial compared to kind of standard care. I think it's not a particularly controversial statement based on those results. And I guess then from a clinical implications point of view, the issue is then, well, is this something we start to do with all our whiplash patients, or do all the physios need to start doing stress inoculation training? Because I feel like done badly, it could go really badly. So I feel like you would actually need to be competent at what you were doing here before you actually bring it into a clinical context. I think
you give an example of how it could go really badly.
I could just think of, could you imagine trying to, like, someone comes to see you as a physio and you're suddenly talking to them about problem solving and stress without kind of the nuanced delivery that a clinical psychologist knows how to do, or knows how to teach you how to do.
It reminds me of like the pain neuroscience education side of things, where like you're trying to explain pain to a patient and then like y'all both get confused and then there's no takeaway. Like that's, you said that's how it works with the patient.
Yeah, absolutely. It could just go so wrong, couldn't it? So yeah, I think like everything, being competent at the treatment is a good first step, and that's something that I think is going to arise from being taught how to do it by proper clinical psychologists. And then we'll see, this might be something that kind of expands into, maybe it might end up more of a specialist training thing. The physios working in trauma or in emergency departments or outpatient clinics where they get a lot of these patients might start to kind of take on as kind of postgraduate training, or I don't know, but it's certainly an interesting consideration. I guess part of the discussion, I suppose, in a paper is about comparing it to other trials. So I think the main point of comparison this paper makes is work done in the UK, the MINT trial. And so I think the kind of main point of interest, I think, for that is that the MINT trial didn't find quite as good a treatment effect, but they seem to use a much more broad kind of shotgun approach to psychology for their patients. So I think that we kind of, in the context of this UK trial, would say that the stress modex trial seems to have gotten a better outcome by being a little bit more precise, by targeting stress, which we know is a really important factor as for predicting who's going to go on to develop chronic pain. We think it's involved in the physiology of transition to chronic pain. So I think that's probably the main point of comparison there.
Scott, what are your thoughts on, because there is kind of the controversy of when you have papers, and maybe I think Paul had brought this up early on, of when you're doing treatment or when you're doing protocols where it's A compared to A plus B. So you see that a lot with like manual therapy of like exercise and then exercise plus manual, and it's like that almost always wins out. And is it because manual is so magical, or is it because you've added on something else? And I think what kind of helped with this paper is like the time was the same, so you can't really use that argument of like, well, you just spent more time with the individual. But what are your thoughts on that, of like maybe an individual's perception of like, if two things are being done to them, it just may be a more powerful kind of input into them of like, oh, this is more of a impressive treatment because it's multiple things?
Yeah, that's a good point. There is certainly that placebo effect comes from perceived, I'm receiving better and more treatment, so I'm going to get better more. I guess maybe from the research design point of view, you could try to address that by having sham stress inoculation therapy, which I don't know what that would be, if it's kind of chatting about the weather or something. But again, that's still going to have an effect. I think from a research methods point of view, you can tease out, there's this thing called network meta-analysis, which is kind of like this fancier version of meta-analysis where you can kind of pull, when there's lots of trials combining lots of different treatments, you can actually try and pull out exactly what treatments within different combinations what's the actual effect of that. Anyway, I can't explain it well, but basically if you've got a study that's got like exercise and manual therapy, exercise and advice, exercise and, I don't know, medicine or whatever else, you can actually pull together the common effect of that one treatment that's common between different trials, and then come up with like an overall estimate of the actual effect of that particular component. So I think things like that more sophisticated meta-analysis approach might be able to give us answers about exactly what our individual components are doing, but you need large numbers of trials to actually be able to do that properly. So I think our group's got I'm not an author on it, but my group's got a network meta-analysis on exercise for neck pain, hopefully being published soon. So Rutger Deserter is the lead author on that, and I think Michelle's the last author. So that'll hopefully come out soon in British Journal of Sports Medicine. So that'll at least be able to tease out as to what particular types of exercise seem to be effective for neck pain. But it is part of the challenge, because in real physio, we do lots of different treatments. You don't ever just give one particular intervention by itself. So picking what is it about what we do that is or isn't helpful is a complicated question.
And kind of on that, like, combined treatment having like a more significant outcome, I think one thing I appreciate about this study, and sort of makes me not necessarily worry about that like factor as much, as how like longitudinal it is, right? Like in my mind, I would think, okay, if those treatments, like they got 10 treatments and it was in the 5 weeks up front, like that combined almost whatever placebo-ish maybe effect could happen in that short term, like to carry on throughout, a year-long trial, also sort of makes me a little less like wary of that. Does that make sense?
Yeah, I suppose it's the flash novelty of stress inoculation as a novel treatment is probably going to be less, want for a better word, less shiny at 12 months time than it is at 6 weeks. So having the kind of the long-lasting effect and the long-lasting difference between the two groups is a pretty reassuring aspect of the trial, I guess. And I think more broadly, the whole idea of short-term pain relief versus long-term pain relief, like long-term is kind of the main thing we're interested in. It's like short-term, you can just give people endone, right? You can just give them opioids and the pain goes away, but that's not a long-term solution to these people's issues. So I think it's that kind of 6-month and 12-month follow-up that's the most important thing for trials on chronic pain.
I know the pamphlet was included in both of the groups as like a take-home read, I guess. I think it'd be cool to have like a study comparing like a third group here where it's like the stress inoculation, but it's through like a text format or through like a module format, like maybe a video that they watch at home, and comparing like, is it as effective, like if the exact same things are being said, or is it less effective because you're not actually interacting with a human? That'd be kind of cool.
Yeah, I don't know. Would be interesting. That's it would make it much more easy to deliver, because you think of all the money and time that goes into training people and then having them come in to see the physio, and and if it's something that can be accessed via an app or even just telehealth, that's a kind of it might be a more practical way of rolling it out. But interesting study.
So I guess wrapping up and like going forward, what is your studies or the group as a whole, like what are y'all the most kind of optimistic about, or the things that you're kind of looking down the next few years?
Yeah, so I think we're got a few ideas in the pipeline. We'd like to do large cohort studies with kind of multi-trajectory modeling, so that's being able to actually kind of look at different outcomes and factors over time and seeing how that actually influences outcome at different time points, which, because we kind of tend to treat whiplash as this kind of homogenous group, but it's actually, everyone's very different. There's different factors that are contributing to people's pain in different people, and so getting better, more nuanced idea if that would help with clinical decision making. I think the use of stratified care in musculoskeletal medicine much more broadly is kind of where it's going. So be able to pick who actually needs help and who can you just kind of pat on the back and say off you go. I think that's a really important thing from a patient care point of view, in that it means that you spend your time with the people that need it and you don't over-treat and potentially over-medicalize people that don't need it. But it's also from a health service point of view, it means you're not just wasting money on treating people that don't need to be treated. I think that maybe, and I think that idea of stress and the incorporation of stress into injury after trauma is really important too. And I think, I mean, the guys across in North Carolina are kind of leading the world in this field. And actually they're doing it as part of the Aurora study, which is this, I think it's funded by the US Department of Defense, and I think it's University of North Carolina, Stanford, and Harvard, and they've got this enormous amount of money to look at everything that happens in people after trauma. So I think there's going to be a lot of really interesting data that comes out of these guys. I think they're after about 5,000 people or something. So it's going to be this massive study of what's happening in people that develop pain and other issues like post-traumatic stress disorder and stuff after trauma. So I think that's going to give us a lot of insight as to what's happening from a mechanistic point of view. And then how to actually turn that into improving treatment. I don't know. I mean, that's kind of another challenging area, but I think the way I've heard it talked about is like a couple of 100 years ago, we didn't understand how infection worked. Like you didn't know why someone's wound got infected, and then we figured it out, and then we can treat it. And so I think it's kind of the same thing here. We don't really know why people develop these long-term pain issues after trauma, but we'll figure it out and then we'll be able to treat it. So that's kind of the grand scheme of where it's going. But at the moment, we're still kind of trying to chip away at that kind of question.
That was magical, first of all. And like, we had a presentation about, Kevin can back me up, of like kind of an intro to insurance, and Medicare and Medicaid and whatnot, and billing and low value versus high value care. And really, like, I think that as you said, there's so much of the population is getting treated from like a musculoskeletal standpoint that either there's a favorable natural history, or there's just not an understanding on their part that there's kind of like this regression to the mean and there's ebbs and flows. And so I really like what you said of like kind of identifying the individuals or the specific populations that really are at the highest risk and that we can have the biggest impact on.
Oh, okay. No, thank you. No, I think that's, probably the most important thing from a patient point of view, but also a healthcare point of view. But then I suppose also knowing who's at risk and why they're at risk is then kind of a nice clue as to what to do about it. It's kind of the ... is the next bit. So I think it's all important insight to gain. But yeah, Sam McLean is I probably shouldn't, if you're recording this, mention his name, just to give proper credit about the analogy about infection. I stole that from him, but also he's leading this large Aurora trial or Aurora study. So, if you keep an eye out for his name as things come out in the trauma and the pain world, he'll, there's certainly going to be really, really cool things that come from that group and that study.
What was his name again?
Sam McLean. So I think this is an interesting twist. I don't know if you guys got it, but here we saw there was like a news article about the first dog to get in the US to get COVID-19. There was like a pug, like a dog actually got COVID-19. It was a big thing, and it's his dog. So Sam McLean, I know like a few people in the US, and that's that guy has the COVID dog. So anyway, Sam McLean leading a pain and ED doc, also with this famous COVID-19 dog.
Of course, the pug got it with like all of its like weird respiratory issues.
It was a pug. Yeah, wow. Bizarre.
Does anyone have any other questions before we call it?
No, Scott, I just wanted to say thanks for coming on today and answering all my questions. I'm not very flashy with numbers or stats, as you said. But well, you didn't say that, but that was the phrasing you used. I appreciate, like walking us through this paper. It's really interesting, especially just like becoming more exposed to like Whiplash papers as well.
Oh, thank you. No, I appreciate that. It's been really nice to get invited, and it's a yeah, you guys are doing way more motivated than I was as a physio student. So if you're 5 o'clock on a Friday afternoon and you're not at the pub, that's a a plus on your point of view. So thanks for the invitation. It's kind of, these kind of things are good from a clinical point of view, in that you kind of keep your head around what's happening in research and kind of improve your ways to trying to understand how research is relevant, or which bits aren't which bits of research aren't relevant, and what you should just kind of disregard. That's also a really important skill to have. And it's also good that you're linking with local clinicians too, because you'll be applying for jobs soon enough, and being having friendly faces in different clinics or hospitals around the place is really good from a career point of view.
Do you have,
and also just flag.
Do you have aspirations in the future to do clinical work and teaching and research, or do you want to stay just kind of the research route?
I do a little bit of teaching, and I still do a little bit of clinical work at the moment. It's a real challenge from a career point of view to kind of combine them all, because research is pretty competitive, and it tends to be largely around your entire worth as a person is based on your grant money and how many publications you've got. So it's kind of finding a nice way to balance them all is a complicated thing, but at the same time, I do kind of keep in the game as a clinician at the local hospital, which is kind of fun in its own way. So there's different ways you can combine it all, but we'll see how things go. I don't know what the universities are like in the US, but we're kind of currently struggling with a lack of money with COVID pandemic. So maybe clinical work's a nice backup to have if everything falls apart in the university sector. But that being said, if anyone wants to come and do a PhD, Brisbane's a great place to come, and we're always after PhD students. So do keep us in mind if you ever get tempted.
Australia just pumps out like researchers, I feel like.
I don't know. I think we kind of had a cash cow with the international student market. International students pay like triple the fees that domestic students do, and so universities just pull them in, and that's kind of funded universities in Australia to kind of produce a lot of research. From a physio point of view, I mean, I'm quite lucky to be at University of Queensland. There's a few big names that have come from there, with Paul Hodges, Michelle Sterling, and Lorimer Mosley, and Gwen Jull, and Bill Vincentino, and so it's kind of a nice research culture there. So it's almost like a productivity breeds productivity. So we keeps us in the game and keeps us interested. So yeah.
Sweet. Thank you so much, Scott. Enjoy your 3-day weekend. Enjoy your little Saturday morning. Thanks for waking up, joining us. This is great.
Yeah. Thanks very much for having me. It's been good fun, and I'm the Pain National Group for the Australian Physio Association. So I think I might try and steal your idea and pull in people internationally to come and speak at webinars and things. It's kind of a cheeky way to do things.
A 24-year-old like random Texas guy can get a dope Australian to come on out of nowhere. Like anything's possible.
No, it's all good. It's kind of nice to be involved. Thanks for the invitation. So
yeah, this is great, man. All right, well, thank you all for joining the party. I'm going to end the call. Enjoy the rest of your day.